Welcome, everyone. On behalf of Centers for Medicare and Medicaid Services, the Administration for Community Living, and the Indian Health Services, I'd like to welcome everyone to the Long-Term Service and Support webinar series. My name is Michaela Holm, and I work with Kaufman and Associates, and I'll be your moderator today. Today's webinar is the many facets of advanced care planning. Before we begin, I'd like to highlight the main features of your Zoom webinar interface. First, the presentation slides will appear in the main window while the speakers will appear in the top corner. At the bottom of your screen is the menu bar, and here you'll find the chat, raise hand, Q&A, and closed captioning functions. Please use the chat box to report any technical issues you are experiencing, and we'll respond to these concerns as they do come in. Next in the chat box is your raised hand feature. You'll be able to use this during the Q&A segment to let us know when you'd like us to unmute your mic so you can ask a question. Another way that you can submit any questions is the Q&A box itself, where you can leave your questions at any point during the webinar for the presenters to address during the Q&A segment at the end of the presentation. And then lastly, live captioning is available for today's broadcast. Simply click the CC icon to use this feature. And please be aware that today's webinar is being recorded, and the recording will be made available online in the near future on cms.gov. With that said, I'd like to welcome everyone to today's webinar. And then please note this webinar series is supported by a contract awarded by Centers for Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in this webinar are those of the presenters and do not necessarily represent the official position or policies of the Department of Health and Human Services or the Centers for Medicare and Medicaid Services. And now I'd like to introduce our presenters, Christopher Pierre O'Malley and Ronna Johnson with the Southcentral Foundation. So please go ahead.
Hello, everyone. What an honor to be here today. We were going to kind of self-introduce ourselves. I am just delighted to be with my wing person, Ronna Johnson, who we're going to be able to share our journey of developing a lot of amazing advanced care planning materials within the Alaska Tribal Health System and Alaska Native Medical Center. So we look forward to just sharing our journey because we've learned so much. A little bit about myself. I was originally born in Albany, New York. At the age of 3, grew up in Florida, and my wife and I did our family medicine residency up in Alaska, the Alaska Family Medicine Residency Program. It was there that I probably spent half of my training in different places like Southcentral Foundation, Alaska Native Medical Center, and hub clinics across Alaska in very remote and rural communities throughout Alaska, which just really inspired my wife and I to work with Indian Health Service. And so I spent 4 years on the Zuni Pueblo, working with a number of Pueblo tribes, including Zuni itself and then also Navajo Nation. And while I was there doing full scope family medicine, I was also their diabetes director and had the privilege to be the palliative care program director at Zuni. So that was just an amazing place for me to learn. I then had the opportunity and was asked to come up to the Alaska Tribal Health System to do fellowship training where I did my hospice and palliative care fellowship at the Providence, Alaska Medical Center, so that I could help build a palliative care program for the Alaska Tribal Health System. And so I was at Alaska Native Tribal Health Consortium at ANTHC, and I was there for about 6 years. And for the past 3 years, I was really excited after having the chance to build a palliative care program there to join Southcentral Foundation, which is just across the street, and really drive palliative care or primary palliative care upstream through SCF's wonderful and robust NUCA model. And their NUCA model is really about providing whole person care with a team-based approach. listening to customer owner's story. And so throughout our presentation, we may mention patients as customer owners because we refer to our patients as customer owners. But I just absolutely love the model here at Southcentral Foundation to integrate primary palliative care services upstream. And so it's been an honor to be here as an integrated consultant doing palliative care, working with primary care teams, both in the village setting, home-based setting, as well as outpatient setting. So that's just a little bit about myself. Most importantly, I would say is I'm a dad with an amazing 5-year-old and 7-year-old. And my wife, Barbara, we love Alaska and love the outdoors and spending time as a family. So that's another important part of what matters most to me too. So I'm going to turn it over to Ronna to share a little bit about herself as well. And so Ronna, I'm going to hand the baton to you.
Hello, good morning or afternoon. I'm not sure where I am right now. But wherever you are, welcome. Thanks for coming and spending some time with Chris and I. So my name is Ronna Johnson. I am born and bred in Alaska. I'm Alaska Native as well on my mother's side of Athabascan and Atlee descent, raised on the Kenai Peninsula. I have been in the tribal health system working as a nurse since 2003. And most recently graduated with my adult Jerry nurse practitioner in 2017 from Clarkson College in Omaha, and have been spending a little bit of fun time working as a nurse director in Southcentral Foundation with primary care, as well as I do my practice hours in the shelter-based clinics that we support. So I kind of have the best of all worlds. I think I have a very wonderful job and a wonderful team that I'm able to hang out with and support. So super happy to be talking with Chris about this. It's a topic as palliative care practitioners who are very near and dear to our hearts as advanced care planning, especially in the tribal system. It's definitely a challenge, but we'll talk a little bit more about that as we start. So I'm going to ask Tom to advance the slide deck and we'll go from here. So advanced care planning, sometimes people just don't even know what the heck we're talking about. So I wanted to start off by saying that advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. The goal of ACP is to help ensure that people receive medical care that is consistent with their values, goals, and preferences. So that's really, really important. So advanced care planning, a lot of people think that it's for old and sick people, and that's not true. Anybody over the age of 18 can have an advanced directive, and we encourage it. And we'll share a little bit more why that's important in our tribal health system on the next slide. So in our tribal healthcare system here in Alaska, it's just we'll go over a little bit more in the next few slides, but on the grand scheme of things, communication across our system can be really challenging. So Alaska is geographically vast. There are lots of ways that our customers and patients can enter our delivery of healthcare. So they could, be in a village site, they could be, in the urban site, they could be in lots of different places. And so it's really important for us to kind of have a good source of communication and talking with one another. There's also transient medical providers in rural sites. So a lot of our village sites don't have people that know our patients and our customers well. So again, we can kind of capture goals and values and preferences of our people, really, really help us in the long run. There's also variations in the way that we're capturing our information on our medical records. So we have lots of different medical records, even across our tribal system. lots of ways to store data, and some of it's organized and some of it isn't so organized. So this is another reason why advanced care planning is really important. But probably the number one thing is the top causes of death among Alaska Native people are cancer, heart disease, and the most important one is the unintentional injury. So 49.4% of all deaths here in Alaska are unexpected, which has been kind of, I think, a passion where Chris and I really started to get interested in developing kind of a more culturally tailored directive. So we'll talk more about that in a second. So next slide. So this is kind of an overview of our Alaska Tribal Health System. It's the largest and most comprehensive health organization in the United States, and with more than 99% of our health programs managed by tribes and native organizations. I'm very proud of that. Here in our tribal system, we serve over 224 tribes and approximately 180,000 Alaska Native or American Indian people throughout predominantly roadless land. So a lot of our places and health systems and health delivery systems are off the beaten path, accessible probably by airplane or boat, snow machine sometimes, but not a ton of roads. And then that all leads to one tertiary hospital here in Anchorage, 103 or 173 beds. And it was Alaska's first level 2 trauma center, kind of in response to that trauma that we get. We have that unintentional injury with people having fishing accidents or four-wheelers or snow machines or all sorts of stuff that happens in kind of a rugged country such as ours. So next slide. So when we do this, and many of you have probably seen this slide, but this is giant. I mean, I'm born and raised in Alaska, and this slide still wigs me out. When you think about, the panhandle of our state stretching and touching to Florida, and then the Aleutian Islands kind of popping up on the coast of California, and thinking about our tribal system being responsible for the delivery of healthcare and services to our people throughout the state, it can be a little bit daunting. So this graphic just, again, is a reminder for myself and all of you to just see the complexity of what we're dealing with. Next slide. So when we're looking at this one, this is just to really show you the regional health corporations, and as they kind of act in the state. So each color is a different region and has its own health delivery system and own medical, like regional medical center. And we at Southcentral Foundation supports and operates in 55 communities throughout Alaska. So again, it's just a kind of response of the complexity of the geography here. Next slide. And these are some pictures. You can kind of see the variation of our health centers. So some are beautiful, some are absolutely amazing with our services, and some of them are little teeny weeny little places, maybe in metal buildings. The one wonderful thing about our community health centers, though, is they're all wired with broadband internet. And that is really what's helpful for us to be able to partner with our ancillary medical services to make sure that we're able to provide support and diagnostic from many hundreds of miles away. Next slide. So when we're thinking about advanced care planning in our state, holy cow. I mean, I remember having this conversation with Christopher in 2013, and it was like, where do we start? really truly, when we were setting up the palliative care program for our tribal system, the few words that kind of came out of our mouths is, how do we get this upstream? How are we proactive? Because really truly, with our manpower and the vastness of the system, if we weren't really intentional about the way that we were setting up delivery of our services and palliative care, we were going to be sunk. And it was really our goal across the system to be able to allow high quality palliative care in some form or another to be delivered in any community in Alaska. The one thing that we did initially was we kind of started with a survey to some of our village health aides and village providers to say, what do you guys need? How can we support you? Because we all know that we could spend a ton of time and effort and energy developing a system, but if it's not useful and for the end user, which is the providers in those little villages, we really have spent our time wisely. So we started upstream, trying to find a more proactive stance to address this. And really, when we leaned in, they wanted to have more customer voice. We wanted to hear like what is important to them. So identifying the customer goals, the wishes and the preferences to really anticipate the needs. How do we provide meaningful interventions? And most of all, how can we keep our customer owners home in their communities when they want to be? A lot of times, when referring back to that first slide, talking about kind of that transient provider population in our rural sites, a lot of them are going in kind of green. And many of you in Indian country know that, a lot of the new providers will seek critical access areas because there's good loan repayment, but there also comes with a cost. And the cost is they can see anything walking through that door. And so a lot of times that can be really, really scary if they don't have a lot of support. And what that means to the end user or our customers is sometimes they're sent into Anchorage, which is way, 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 way far away from their home and their loved ones. And they're sent to Anchorage at a huge cost to our health system to go somewhere they don't want to go. And so we've seen that a lot. And we're seeing it less, thank goodness, with kind of the advanced care planning push that we've had. But it's just really important to make sure that, just because we can doesn't mean we always should, and making sure that we have those conversations early and upstream to make sure that everybody's on the same page and support people where they want to be. Next slide. This is a study, actually, Julie McNulty was one of my mentors moons ago in the tribal health system. She was not Alaska Native, but she was one of the fiercest advocates I've ever met for our people. I was fascinated by the rural connections that were made for our people in the villages, and how people, with so few resources could have such robust kind of attention to people in their villages. And when she started kind of looking into this, she was basically studying kind of cancer care and survivorship in the rural settings. She realized that when people are at home, it's counterintuitive, to a lot of us. We think that we get better healthcare when we're near a hospital, but she found actually quite the opposite. That when people are home, that their stress is reduced, and we know, as Native people, we know that mind and body are so connected, and that reduced stress level actually was better for people, that they were able to kind of ground themselves at home. There was limited travel and care coordination. They weren't so medicalized. There was definitely a stronger sense of community and connection, both informal and organic. Whereas In the urban population, she saw more of an intentional connection, more formal relationships with medical providers or, people within a home setting or a hotel setting or something. People would make interactions and community, but it was definitely a little bit more forced and not as juicy as it is at home. Whereas if they're home, they'd see somebody in grocery store, and they could look at them and say, you're not feeling well. And there was a support that came along with just that knowing of people and that relationship that was built. And that public journey of survivorship alongside with a whole community watching, people were able to kind of gain strength and inspiration from either, encouraging them with them at home or just like embracing them and support and giving them help and supporting those needs. There was also more of a comfort and normalcy at death. Again, it really spoke to just the informal support and the robust support that people in home communities give to one another. So that her little pearl here of this research was really, really helpful with kind of pushing some of our work forward. So I'm going to turn it back over to Chris to talk a little bit more about next steps.
Thank you, Ronna. I appreciate Ronna just talking about the benefits of rural healthcare and just how does advanced care planning help our customer owners. I wanted to share a couple of stories that kind of support all the things that Ronna just shared. Initially, when I was a family medicine resident, one of the things that really sparked my interest or helped me to see the importance of advanced care planning was, as a resident, as I mentioned, had the opportunity to go to Bush, Alaska. And so I remember being in YKHC out in Bethel. And in part of my training working at that hub hospital was to go on medevacs. And so it was in February, I remember, and I went to a village in the very far western side of Alaska. And while I was there, it was off the road system. The only way we could get there was flying with a medevac team, just amazing advanced practice nurse practitioners that were also paramedics who were on this flight. And so I would go with them to all the different villages. And what was amazing is YKHC as a hub served an area that's the size of Oregon, the state of Oregon. They were responsible for about 55 villages. So on this medevac, we land and we get off the plane and we're met by a snow machine with a sled. And so our team loads up all the medical gear on the back of a sled. And it took about a 20 to 30 minute snow machine ride to get to the community health aid clinic or the village clinic that was there. Man, talk about exhilarating. I'm this family medicine resident and I'm like, wow, this is amazing. This is incredible. Well, we arrive at that village clinic. And what was amazing is here's this community health aide who has this young gentleman in his 40s who is on the floor and he's obtunded. And so we find out that he has liver disease. Now I realize it was probably more like end stage liver disease. He was febrile and not responsive. We quickly, went into action and we ended up having to intubate him. So we had to secure an advanced airway on the floor of this clinic. We had to start IV. We actually started pressors because his blood pressure was so low. So he was septic. And so, here we are doing all these advanced interventions. He's all by himself. And next thing we know, we pack him up in a down comforter. We put him on the back of a sled on a ventilator. We had a portable ventilator. And here we are on a snow machine and sled going back to the plane, which took about, again, another 20, 30 minutes to load him up on our plane. And then the plane flies to Bethel, which took a little over an hour, almost like an hour and 15 minutes just to get to the Bethel runway. And then the next thing you know is there is a jet airplane waiting on the runway because they need a jet airplane that takes an hour and a half just to get to Anchorage, where he can get ICU level of care. And so it was amazing. So as a family medicine resident, I'm like, wow, like I'm doing all of these aggressive medical interventions, which for me, it's experience. Like I got to intubate, I got to start a line for pressors and all these things. So mechanically, there's so much education in that, right? But then when I reflect on that experience, all these questions came up in my mind. The one question was, who is this person? What is his story? I wonder, did he have an advanced directive? I didn't even know. I don't think the medical team even spent the time to ask, because when I look back, the things that I don't know about this person is his story. Here's a person who probably has connections with family and people he loves. Here is a person who was taken away from his village, from his culture, and he was brought to Anchorage, where I'm not sure if he ever recovered, but he may have just died in the intensive care unit there at Alaska Native Medical Center, that main tertiary hospital. But the thing that struck me was, what were his goals? Were those conversations ever held to know what he really wanted? And what breaks my heart is that I don't think his goals were ever captured. And so I don't know if all those interventions in him being brought out of the village really was what he wanted. And that just, it leaves a place in my heart to say that these conversations are critical. What matters most to someone? Our customer owner's voice matters. And as a physician and as healthcare teams, we have the responsibility to ask and inquire what matters most and to capture those goals, especially end-of-life care goals, which an advanced healthcare directive does. Well, let's fast forward, and here I am in Zuni, working in Zuni. And I just want you to know, I was so inspired by this team that worked in this amazing pueblo of Zuni. And what I learned from my patients there at the Zuni Comprehensive Health Center was that here I am doing ER medicine. I'm admitting people to the inpatient service, but we had a runway right next to the hospital because anyone who needed a higher level of care oftentimes had to go to Albuquerque, which was anywhere from 2.5 to 3 hours away, depending on weather. And so we would have to fly them there to get them there, urgently and medevac them. So it was very similar to Alaska, a lot of similarities. But the thing that I realized talking to my patients in Zuni is that there were a number of elders who, even though they were going through the signs and symptoms of a stroke, a CVA, or they ended up having signs that they were having an MI, like a STEMI. The thing that I realized that a number of their elders chose that they did not want to leave Zuni. They wanted to stay home. And what was so amazing is that the hospital that I worked at supported that. So if their goal was not to go to Albuquerque to get a higher level of care, their goal was to stay in the hospital, they actually had these amazing facilities that allowed for comfort care and allowed for management, medical management, so that they could be home surrounded by their culture, their family, and their friends. And that just, inspired me so much when I look at that other story. And it's one of the things that I realized. I was just like, the Alaska tribal health system, the Alaska Native people, they deserve that same level of care. And that story that I have of going on that medevac in Alaska reminded me how important it was to come up here, because quality palliative care and advanced care planning is a part of that, should be universal across our country. And it's just so sad that oftentimes rural and remote communities often lack quality palliative care. And to me, that's a tragedy, and that's what drives me every day to do the work that I do in palliative care. So this slide talks about how does advanced care planning help. I hope those stories show you that, number one, it honors the wishes of Alaska Native and American Indian people. It clarifies those goals and preferences. It improves communication, most importantly, amongst the family, so that everyone understands the goals of our customer owners. But in addition, with healthcare teams and across healthcare systems, it improves communication. It satisfies meaningful use requirements and promotes quality of life. And again, those stories capture, especially what I've seen in Zuni, is that quality of life. It's important that you decide where you want to be, especially when time may be short. And so, the thing I would focus on is advanced care planning is not about a bunch of forms. It is truly, truly about the conversation. And so I just want you to know that conversations are lifelong. Our goals change throughout our life because of experiences. And I would also mention too, that I've learned so much from my patients and customer owners. And one thing that they've taught me is that we need to be humble in these conversations. We need to bring what we call cultural humility to these conversations, because every individual is an individual. We all have our own stories and our own experiences. Some of us may be very traditional in our values and our customs and our culture, whereas others may have more of a Western perspective. But we need to keep that in mind when we have these conversations, because there are some communities where there are taboos, or talking about end of life can be very difficult. And as healthcare provider, it's important when we have these conversations that we ask permission, or ask how best can we ask questions or communicate information about advanced care planning. So I just share that with you to say that I think that is a key piece of training and learning, is how to be humble and to learn from the person that's in front of us, our customer owner, so that we know how best to talk about these tough topics with advanced care planning. And what we find is that in the end, when we follow the wishes of our customer owners, people often do not want lots and lots of aggressive care, but they really want to be sometimes at home, and I would say most oftentimes at home, surrounded by their culture, their family, and their friends. And that's where that last point comes in, just to say that when we follow people's goals of care or their wishes, it often leads to less medicalization. So we're spending tons and tons of money at the very end of life, when oftentimes it is not aligned with the goals of our customer owners. And so that's another reason why advanced care planning is important. Next slide. So Ronna had mentioned, when we first started, we were just like, wow, okay, we're gonna build a palliative care program for the Alaska Tribal Health System, something to serve the Alaska Tribal Health System. So it was pretty daunting. And so we realized that we needed to do a needs assessment. And through our needs assessment, what was number one in that needs assessment was that our healthcare team members were saying that we don't know how to have these conversations. We need advanced care planning tools. because they didn't have tools or the training to have these conversations. In addition, they felt like they wanted culturally tailored or culturally appropriate tools and materials. And so Ronna and I realized that, wow, that's really the first step we need to take while we're building palliative care services, is that we really need to address the elephant in the room and help providers with advanced care planning to improve communication throughout our system. And so that's where we started, with our advanced care planning pilots. And this was actually, it's funny, Ronna and I started in 2013, we realized the Alaska state advanced healthcare directive was so cumbersome and so hard to use because it had so much legalese in the state advanced directive that it was written at a 16th grade level. So you needed a master's degree to be able to decipher it. And so no wonder why people felt uncomfortable having these conversations. So back in 2013 and 14, Ronna and I started working on saying, well, gosh, we need to create a new advanced directive for the Alaska Tribal Health System that was culturally relevant and adapted to our system. And so, that's one of the things that we're going to talk about and share the resources that were developed. So that was part of this pilot. We realized that we needed to develop these materials and tools, but it's not just about having a form, because again, it's about the conversation. And so the next part of this was the clinical workflow. Like, how do we integrate advanced care planning tools and resources, in our workflows of primary care clinics, specialty clinics, within the ICU and in inpatient settings? How do we do this in the village settings, at the village health clinics, in the hub hospitals? So how do we share these resources statewide? Because again, the Alaska Tribal Health System is made up of separate entities. And so we need to be sharing and collaborating together, because you can't take a cookie cutter approach. So these were some of the challenges that we faced with this pilot that we did. We also realized, again, that healthcare teams said that they needed education. And so we were like, wow, how do we educate people who are in different systems? And the thing to know is that we needed to educate thousands of people. And so how do we do that when it was just Ronna and I? So that was another part of this big puzzle that we had to figure out. And so what I love about Southcentral Foundation is that they don't just jump in and do something and hope that it works, that they really do PDSA models. So they have this incredible, these improvement teams that help guide us through the Plan, Do, Study, Act. And so this collaboration was through the Alaska Native Tribal Health Consortium and Southcentral Foundation. We came together to say that we're going to do this pilot together to not only impact our specialty clinics in an inpatient setting at the Alaska Native Medical Center, but also Southcentral Foundation's primary care center as well. Next slide. One of the things to know about too is, it's not just about the perspectives of our healthcare providers, right? We really need to get customer owner insights. And so what was awesome was Southcentral Foundation has Jen Shaw, an amazing researcher, who was able to do focus groups, because especially from my experiences working in Zuni and Pueblo tribes and also Navajo Nation, I also knew that there are taboos here in the Alaska Tribal Health System as well. And so these focus groups helped us to realize that we needed to use content that was fewer words, simplifying the content. We realized that there's so many languages spoken in Alaska that we need documents that are easily translatable. And so we were like, we have to keep that in mind. We needed to make sure that we replaced jargon with plain language. And And we wanted to, make sure that advanced healthcare directives were applicable to a variety of illnesses or diseases, whether it was a serious injury or illness. So for example, dementia, COPD, congestive heart failure, a lot of different things happen. So we wanted to have a form that that broadly addressed serious illness and serious injury broadly so that it was applicable. We also realized that it wasn't just about providing training to the healthcare staff. We felt so strongly, and this is something that came out of the customer owners, they needed to own these conversations. They needed to feel a sense of empowerment that they can bring up with their providers, that these conversations are important and they want to talk about these things and they want to document their wishes. And so we realized public relations was a huge part of our initiative because it wasn't just about training providers, it was about training the community because we all had a responsibility in these conversations. And we all could inspire because, not only am I a physician, but I'm also a father, I'm a husband, I'm also a child of my parents. And so this journey got me excited to be like, well, gosh, I need to share this with my family. And so me filling out an advanced directive with myself inspired my friends and my family to also do that. So really it's a community response, advanced care planning. And so I just want to break down those barriers. This is not a healthcare issue. This is a community issue that we all have a responsibility to be involved with. And so other thing I want to validate is that there are studies that show that a lot of times providers are afraid that these conversations are going to take away someone's hope. So studies have shown that these conversations do not take away hope. And these focus groups validated that. And our customer owners said, that these conversations are important. They don't take away hope. If anything, they help people to plan and make appropriate choices for the future and guide their families to bring them together to know what their wishes and their goals are. Next slide. So provider insights, even though I think studies have shown like the majority, it's like 98, 99% of providers feel like these conversations are important or knowing goals are important. But yet, like, I believe it's like 30% actually have these conversations. So there's this huge disconnect. And the big question is why? And so through our assessments, we also ask providers, we're like, what are the barriers? What are the boundaries? Or what are the barriers or the challenges to having these conversations? And I've kind of alluded to these things already, but they wanted a form that made sense because I want you to know there's thousands of advanced directives that are out there, but a lot of them are hard to translate into orders or into medical practice. So we realized, we knew that Alaska was bringing on board the pulsed paradigm or the pulsed model in the future, which this year I'm so excited to say that Alaska is now a member of the pulsed paradigm, and we have our own Alaska Pulsed, which is a form that creates order sets based off of the wishes expressed in an advanced healthcare directive. But what's exciting is that we realize that an advanced healthcare directive needs to be translatable or be able to be meaningful for healthcare providers to know how to follow someone's wishes. So we kept that in mind. We also realized that providers felt uncomfortable because a lot of them lack education in communication and how to have these tough conversations. And so we've done a lot of work on creating resources, including, for example, and we'll be talking about this, we created modules through our learning management system that were shared across the Alaska Tribal Health System. And one of those most important modules was, how do you have advanced communication skills? And how do you teach those? And so we used, the nurse mnemonic to teach about emotions. And we also use spikes which is not only used on how to deliver bad news, but also how do you, lead family meetings and have sensitive conversations. So we used evidence-based communication strategies and skills that providers could incorporate in their practices, not just with advanced care planning, but just in general with delivering information about serious illness and serious injuries. And so, and then we also realized that, our providers and healthcare team members need to have tools and resources so that they know how to facilitate these conversations. So we're going to share how the materials aren't just education materials, but they're actually tools for providers. And when I say providers, I want you to know that we have the expectation that anyone can have these conversations, whether it's our behavioral health consultants, or whether it's an RN case manager, or a home visiting team member, a provider, a community health aide. We want everyone to feel like they have a role and responsibility in having advanced care planning conversations. And the tools and resources that were developed were there to inspire people that they have the guidebook or suggested scripting to be able to have these conversations. Next slide, please. And so one of the things I was just going to share is that from the pilot data, we realized that it's not just about a form and it's not just about the conversation, but there is a lot that goes into holistically creating advanced care planning models. So process and teamwork, these conversations take a lot of time. For me, oftentimes it takes an hour to sit down and to really be able to listen to goals of care. And so advanced care planning conversations, your providers or the staff members who these conversations are handed over to need to have protected time and space to do these conversations well. Tools and technology. So one of the things is, oftentimes, all the different materials are overwhelming and it's hard to integrate them in busy clinics. So what we realized is that we needed to leverage technology so that on our websites, all of our materials are easy to find, easily downloadable. You don't have to have a shiny glossy copy. You could just print it out of any ordinary clinic printer, because we realized that having tools that are on the internet and easily downloadable and accessible make it easier when these conversations happen in the moment to be able to document them on an advanced healthcare directive. And so what's awesome is if you're in a village, thousands of miles from Anchorage, you can easily access these as a community health aide. And so that was important to us. The other thing is we realized that you could have 100% compliance of having everyone fill out their advanced healthcare directive. But if you get it scanned into the electronic health record, which fortunately our Alaska Tribal Health System is mostly on one electronic health record, we're getting closer and closer to that goal. If you scan it in and you can't find it, or your providers cannot locate these documents, they're useless. And so we realized that we also have to look at the electronic health record and find easy ways to make these documents accessible. Conversations and in our customer owners. So the more that our customer owners felt empowered to ask for these conversations, and the staff felt like that they had kind of a guidebook on how to have these conversations, we realized that those go hand in hand to making these conversations happen. Next slide. So this is a slide just to kind of share some of our data. I want you to know, if you look to the left, what was amazing to us about this pilot, we started to run the numbers, and for those 65 and up, we were looking about only about 1% or 2% of our elders 65 and up had an advanced healthcare directive on file. It was just like, we couldn't believe it. And I know, Meaningful Use has often said that, we should be more like 50%. And so, but what's amazing is we're running the preliminary numbers after the 5 years that this has been into play. What's amazing, and we're going to verify this, we're getting the data right now to be able to write this up, but we're now getting closer to 30% of those 65 and up have an advanced healthcare directive on file. So to go from numbers of like about 2% up to 30% just shows how remarkable it is that these tools are really helping in these. And again, it's not just about the forums, but it's about the system-wide approach that we took to implementing advanced care planning. It's exciting to see. So I'm going to turn it over to Ronna with the next slide to continue.
Hello, good golly, it is exciting to hear about this, and especially for Chris and I, we can geek out on this all day long, and we'll geek out later because it's just been such a long and exciting journey to see this kind of know that this is not just, again, it's not numbers, it's conversations, it's, hopefully every single person that's filled out one of these papers has gotten their wish, that we've honored them and that we've kept them home, or that we've, continued to do treatment, if their family was confused and what to do. It just makes me happy to know that there are real people that are on the backside of that, and hopefully feeling better about that and choices. So I've got two competing things that are very exciting to me to talk about. I think I'm going to continue talking about the advanced care planning materials, but Cindy Schlo, I think if I say that, Schlo, brought a really awesome question front and center about the causes of death and understanding death among Alaska Natives related to suicide or self-harm. So I really want to dig into that too. But let me on the advanced care planning materials, since we got people on the edge of their seat, I'm sure trying to find out what's next. So this is kind of a little couplet that we developed with the advanced care document directly, a facilitator's guide, and kind of a placard brochure that you could introduce the conversation without putting out fancy, shiny materials that Chris was talking about. And we'll go over those in detail here. Next slide. So like Chris was talking about, we were super excited. Chris did a lot of work pushing that pulse through the physician order for life-sustaining treatment. It's a new form here in Alaska that we were able to use as an expected form, as well as the traveling kind of order, medical order, which is really, really lovely, especially when you refer back to how big our state is and how difficult it is to move people around. That's exciting that pulse was implemented. The advanced care directive, though, was also something that we were very proud of, because it was simple language, easily translatable into native speaking languages, which was very exciting. We worked with the universities to make sure that there was something to actually comprehend if somebody was not speaking as English was not their first language. Flesh Kincaid reading level was brought down to level 6 instead of level 18, which again was super duper exciting. So this is a very helpful document because it speaks not only to the values and preferences of people, but it also is very easily used as a springboard in a conversation, in kind of a just-in-time conversation at the bedside if somebody is getting ready to be admitted, or if they're not able to make their own decisions, to kind of help guide families or their loved ones to help them make those choices and use that customer voice. Next slide. So the planning, the conversation guide was something that was pretty dang clever, if we don't say so ourselves. So the theme is be prepared. And in Alaska, doesn't matter if you live in an urban site or a rural site, people know what it's like to be prepared. We bring our jackets, we put, protein bars in the glove box in case you go off the side of the road, all that stuff. We know what it's like to put fish up and put it in your freezer and pick berries and prepare for winter. So we kind of jumped off of that cultural tagline, really, to wrap that into an intentional design and intentional communication tools. The facilitator's guide, again, still easily translatable. And if you look at it, it's hard to see. I know, actually, there's another slide coming up, so I'll go into detail next. So, Tom, can you advance to the next slide? So the storyteller or the facilitator's guide, the one thing that's very exciting is that it incorporates storytelling. I think Chris and I both spoke to. A lot of times it's very difficult to solicit ideas or conversations sometimes. A lot of people maybe want to talk about it in theory, or maybe they want to use third person. So storytelling is very culturally appropriate here in Alaska. And we use that, again, as the integration of the AN and AI culture, using 3 real life scenarios addressing decision points. So the first one was be prepared for the unexpected. So the unexpected is a story about a little healthy young man who basically gets in an accident and he has a head injury and he's not waking up. And so it's kind of solicits, you read that story and then you solicit a question like, and if this were to happen to you, what would be most important at that time? There's also one that's a journey related to a young woman with a new diagnosis with then also progression of disease. And then the next one is the transition. So it would be somebody who's an elder or having, multiple medical challenges in the end of their lives. You can kind of look at it and guide it and go over a story that's most appropriate. So maybe somebody who's really young and healthy, you would go to the unexpected, because again, that's where most of those unintentional injuries would occur. So somebody falls off of their snow machine or gets conked on the head in a boating accident or something like that. But if somebody has a new diagnosis of cancer, maybe you'd use the journey story. And if somebody's an elder, you might use a transition story. Next slide. The facilitator's guide itself is really interesting. It looks very much like patient education, family education. But if you look at the blue script, it's basically suggested scripting for the provider or the person that's kind of guiding somebody through that conversation. It allows you to use open-ended questions that maybe sound a little bit more like your conversation or your conversational tone, so that it's not like weird language that somebody else came up with. It becomes very conversational. It's a very much a customer-centered discussion, and it encourages interactions. And the cool thing about it too is that the content is linked by the page number to the advanced directive itself. So you can kind of flip it back and forth and use both of them kind of concurrently to fill out the directive while you're having this conversation. So that's kind of cool too. So I want to stop for a second because the next slide is Chris's, which is very exciting too. But I kind of wanted to get back to what Cindy was talking about. She wanted to kind of discuss about the understanding death among Alaska Natives related to suicide or self-harm. And I think that's a really important topic. And unfortunately, historical trauma is alive and well in the Alaska Native population, and my family for sure. Families in general are very messy. But then when you get kind of the loss of a culture through the colonization of the Alaska Native people, there was a whole kind of uproaring that happened, and cultural or historical trauma, if you're familiar with it, it can be definitely used in multiple cultures across the world, but has it affected in Alaska? There was a lot of people that came to us and they were basically taken away from their families and put into boarding schools. They were beaten if they were speaking their own language. They were, forced to assimilate into a white population and a white culture, often away from their family. So what happened was you get these kind of ghost cultures where they no longer fit into the culture that they don't fit into the culture that they're being assimilated in, but they also don't fit anymore into that traditional culture, which leads to a very weird space where it's a loss. It's a compounding loss that lasts over generations. And if you do some research around or reading around historical trauma, a lot of times the further away you get away from it, some of the more abusive behaviors that come out, such as self-harm, domestic violence, the drug use and addictions, those show up a little bit clearer in generations away from where people were actually experiencing that. And what happens is it actually is shown to change people's DNA. And so the further away they get from it, they've heard the story, they understand the story, they've raised by this. It's almost like the adult child of the alcoholics. You don't have to take a drink to still have some of those behaviors ingrained. And so what happens is there's just kind of a survivalist mentality that shows up. And a lot of times there's grief that's not attended to, and that active form of grief becomes anger. And it can be pretty aggressive and sad and crazy. And until, collectively as a culture, we start to acknowledge it and start to talk about it and start to heal from it and share story about why people are so angry when they don't feel like they have anything to be angry about, and eliminate a little bit of that confusion and that sadness of what the things that we still walk with. Those are keys to healing. And so thank you, Cindy, for bringing that up and allowing kind of to share that story, because I think that that's super, super important. And it's a real thing, and it's well any kind of read or explore for somebody who's thinking a little bit more about that, to dig in, because a lot of times we'll still victimize cultures that have had so much taken away from them, but we don't understand that we are just perpetuating this story. So it's really, really important to educate ourselves. So thank you for that. I'm going to turn it back over to Christopher, and I'm going to answer some of these questions. So thank you.
Thank you, Ronna. We wanted to share with you another tool that is actually on the website that we shared that has all the advanced care planning resources. We call this our wellness map. Something that I realized is, especially when I was the diabetes director in Zuni, what really engaged our patients in Zuni was the fact that when you would involve story and pictures, and this wellness map does just that, it can be a powerful education tool to foster conversations. And so the vision of our wellness map was to show pictorially with pictures of images that people could relate to, especially within the Alaska Native culture, like identify with, number one, a river and water. And so this conversation map, because really, what is it about? It's about the conversation, and it's not about the forms. And so what I see often happen, a lot of times providers who are using just regular advanced directives, they'll sit down and they'll read the form verbatim to the customer owner. And again, the focus becomes the form rather than talking in a conversational way about goals of care. So we use this wellness map in lots of different ways. So just imagine we have this wellness map in our palliative care visits, where when we're explaining when someone's got a new diagnosis, we'll just share that, hey, like this is like going down your journey on a river, and you've never been down this river before. And so the river guide that you see on the left, that could be representative of either palliative care or the healthcare team. But what we try to share with our customer owners is that, you know, you're not alone in that boat. It can be scary as you start this journey down this river, but we're going to be there with you. We've been down this river many times. And our initial goal is to create a map to better understand your goals. So that map really represents advanced care planning. Because if we can understand what your goals are, and we can map out your journey of what's important to you, what matters most, who are the people that matter most, who do you want in your boats, where do you want to end up, we can help to navigate to your favorite fishing spots, or make sure that the people that are around that fire are the people that you love and who you want to be connected with, making sure that if there is a spiritual connection in meaning and purpose, that community is around you as well. So as you look at all the different symbols on that map, those symbols help to foster conversation. And what's awesome about these conversations is that it's not really us leading the conversation, but it's rather having the images allow our customer owners and families be inspired by those images to share their story. And that's what advanced care planning is all about, is listening to story and capturing goals from those experiences that they've had. And again, advanced healthcare directives are one way to capture some of those goals. And so I'm very involved with something called Aging Well Initiative, which is really looking at improving elder care at Southcentral Foundation, but across the spectrum of all ages, because I also do pediatric palliative care as well here within our system. It doesn't matter where you are in life. We even do perinatal palliative care, which is even before birth. You know, serious illness or injuries can impact you anywhere in the spectrum of your life. And so it's just important that we're helping not only our customer owners, but the families kind of navigate through to know where they want to go. So I just wanted to share this tool with you because it's been really helpful for us. Next slide. So, you know, I had touched upon integrating advanced directives in the electronic health record. So we use Cerner, that's our electronic health record system here. But it's just amazing. I remember in the beginning, I believe it was the Mayo Clinic, you know, they had a way where they built in the banner bar a little prompt that comes up saying that there's an advanced directive on file. And so then later on, we learned that you can create an M page. It's called an M page in our system, which is, it's almost like a tab where providers can quickly just click on the tab and find all the advanced care planning documents in one location, so that this way they don't have to be searching throughout their whole electronic health record. We also realized that we have something called dynamic documentation that you can put prompts on the side. So the big thing is there are different ways that you can alert providers or healthcare staff that there's an advanced healthcare directive on file. And in emergent situations, like going to the emergency room or a medevac going into the intensive care unit, it's critical that those things are flagged and prompted so that we can follow those wishes, or at least interpret what's written on an advanced healthcare directive, or especially now that we have the Alaska Pulse, that those orders can be seen you know, quickly so that we can honor someone's medical wishes. So the other thing I was just going to share is our assessments, especially from our customer owners. We heard that they were getting bombarded with advanced care planning questions. So for example, say an admission, as they get admitted to the hospital, you know, the front desk person is saying, do you have an advanced directive on file? Yes or no? Well, then that information would be documented, but it wouldn't be connected or transmitted to the next person. So then the nurse is doing their intake and they're asking, do you have an advanced directive? And they get the same question. And then the next thing the physician comes and does is the H&P. Do you have an advanced directive? And so within one admission, someone may have been asked if they have an advanced directive 5 times, but it doesn't really lead to any systematic workflows to actually get it completed if they have one, or if they don't have one, or if they do have one, there's really no good system in place before this advanced care planning project that we did. There's no system in place to get it into our system. And so one of the things that we developed in our electronic health record is that when someone asks whether they have an advanced healthcare directive, we can document that that conversation was had. And we also use it as a prompt because annually, even if you have an advanced healthcare directive, you should be reviewing that advanced healthcare directive to see that it still reflects the wishes of the customer owner. Sometimes our customer owners decline completing an advanced healthcare directive, and we want to respect that, especially since this is a very culturally sensitive topic. And so one of the things that we can do is it says advanced directives declined. And so having those prompts in there avoids someone being bombarded with the questions of if they have these forms on file or not. So just wanted to share that with you. Next slide. So future direction. So it's really exciting. Right now, we're in the process of, it's been about 5 years since we launched our initial Your Care, Your Choices advanced care planning program. I want you to know another thing that I love about Southcentral Foundation is we realize that there's always opportunities for improvement. There's so much work still to be done to build upon the things that we've been doing. I want you to know internationally, I appreciate Diane Meyer, they're starting to ask, like, what role does advanced care planning really play? Is it possible for people to have theoretical situations or truly know what their wishes are, when they have an advanced serious illness or injury? And so, but the bigger issue here is that it's not just about end of life care issues. It's not just about your goals when you have a serious illness. I think our system in general, across the country, does a poor job of capturing goals. It's hard to find goals that are elicited in visits in an electronic health record. And so I think the future direction that we're looking at, especially with our Aging Well initiative and some of the things that we're doing, across all ages, is that how do we document the acute goals, the here and now present goals, but also how do we document the long-term goals of someone? So for example, when I meet with an elder and they say that independence and aging in place are really important to them, I can document that in my note, but it gets lost. So when they see the next provider, they may have lots of different goals. And so I think it's really important that we capture those goals and communicate those goals in a robust way. And so I still think that there's a lot of room for improvement for advanced care planning, but also just in general within palliative care and goals of care discussions to capture it, but also not just to capture it and communicate it, but to act upon it so that we're supporting the quality of life and doing what's best for our customer owners and families throughout the journey of their life. And so right now we're in the process of doing an updated version of our advanced healthcare directive. So it's going through the process of getting updated. And then we're also looking at how do we do refresher courses for all of our healthcare teams that have been trained. And so what's exciting is we've trained over 3,000 healthcare team members utilizing our learning management system, which we use UltiPro here in HealthStream across the street at ANTHC. So thousands and thousands of healthcare team members have undergone these trainings in advanced care planning, but we realize that it's not a one-time training and they need refresher courses. So we're working on those right now. And then, as I said, we want to really look objectively at the data to see where truly are we at right now, percentage-wise, with motivating people to have an advanced healthcare directive on file, and what can we do to hopefully one day having the majority of our customer owners and family members having an advanced healthcare directive on file. So I think there's so many opportunities. And the other thing that we're working on is the pre-conversation, because customer owners need time to think about these topics beforehand, and then feel empowered that they can bring in a form or a tool or a resource before they actually fill out an advanced healthcare directive. So Dr. Randy Curtis developed something called Jumpstart. And so right now we're looking at ways to adapt that pre-conversation tool to then lead into the workflows for advanced care planning. So there's a lot on the horizon in future. I just so thank everyone for this opportunity to kind of share what we've been doing. So next slide.
Thank you, Christopher and Ronna. We are going to move into, this is our time for questions that we'll be addressing. So if you would like to submit any questions in the Q&A box, we can answer them live, or you can raise your hand and we will unmute yourself so you can ask the question out loud. I know Rona's been answering some questions as we've been going as well. And I saw that one question that's been answered or asked a few times is if you can get emailed the slides. And we will be posting a PDF version of the presentation and recording in the near future on cms.gov. But if you have any other questions, now's your time to post them in the Q&A box and we'll be able to answer them. Okay, we have one question. And so the question is, what is the role of social workers in all of this? Are they exist in Alaska also? Forgive me.
Sure, Ronna and I could both address that. So at social workers, and this is me speaking as a palliative care provider, oh my goodness, what will we do without our social workers? That's all I can say. We absolutely have social workers in a part of our palliative care teams. Social work is built into the fabric of our team. So we couldn't do the work that we do without our social workers. So ANTHC actually has LCSW, so licensed clinical social workers. At ANTHC, within our team, our social workers actually acted in the role of, they wore two hats. One was as a counselor, so they provided kind of behavioral health support, but they also wore the hat of helping with complex care coordination and resources and getting connected, with issues of guardianship and surrogacy and all the complexities that often come up with complex healthcare needs. At Southcentral Foundation, we use what we call a community resource specialist. They are most often not licensed clinical social workers that serve in the community resource specialist role. So what's interesting is the behavioral health needs, we have what we call behavioral health consultants, and a lot of them are LCSWs at SCF that strictly do counseling. But then our community resource specialists are truly experts in the resources and in getting housing assistance and addressing complex needs of guardianship and all those things. And so we look towards our community resource specialists that are are integrated throughout Southcentral Foundation. Ronna, do you have anything else to add to that?
No, I think I absolutely mimic your sentiment for what would we do without them. They're worth the weight in gold.
Great, thank you. If there are any other questions, we'll leave just a few more minutes. Please place it in the Q&A box. We just got one. Do you have any experience or words of advice for potentially connecting conversations about advanced care planning to billing or being reimbursed? It seems that healthcare teams are often pressed for time, and some people might say a 7-minute visit is common. Any financial incentives?
Chris has got this dialed down. I'm going to let him answer this.
So I want you to know, CMS has definitely developed advanced care planning, like ICD-10 codes. So there are billing codes that you can use for advanced care planning. It's time-based. And so I'm not an expert in billing, so I want to leave those to the experts. But from my understanding, and I would clarify this with your experts in billing at your department, is that what's wonderful is that you, as a physician, I can start the conversation, right? And I can get the conversation going. But then what we do here at Southcentral Foundation is, because these conversations can take an hour or longer, you can actually hand the baton off to someone who's trained on your team. So at SCF, we have a behavioral health consultant who steps in, or we have sometimes an RN or community resource specialist who all have been trained to have these conversations and feel comfortable having these conversations. The provider can actually step out, go see the next person. And then what ends up happening is, as long as that person says, hey, I spent an hour and a half or an hour and 15 minutes having this conversation, my understanding is that because of its time-based billing, that the provider can integrate that or document that in their notes. And so, so just know that it's exciting to see that there are changes from a billing standpoint to support these conversations. And I would just reach out to your experts to know exactly how to document those to maximize the work that you may already be doing. One thing I was just gonna share too, which gets back to the social work question. I want you to know, at SCF, we have an abundance of resources. We have psychiatrists, we have LCSWs, we have integrated physical therapists and pharmacists, and oh my goodness, an abundance of resources. I want you to know that a community health aide out in a village, they may be the only ones that are there. And so within Indian Health Service, I want to recognize that the resources and a lot of providers and resources are very spread thin. And so one of the models that we used here in Alaska was Project Echo. So through University of New Mexico, there's this model called Project Echo. And a lot of the training that we provided, we created a palliative care Project Echo. And part of that palliative care Project Echo allowed us to reach out to these community health aides who were quite isolated all by themselves in a village to help support them with communication skills and advanced care planning skills, and just in general palliative care skills. So I just share with you that there are a number of palliative care echoes across the country. And I would encourage you to look regionally to see if there is a palliative care echo, because it's a great way to learn palliative care skills that also translate to advanced care planning. So.
Yeah, we do have another question. Do you have any experience with people consenting to share their advanced care directives across organizations, or perhaps with community agencies or social services that might need to know their wishes?
Yes, I will answer that. So again, Cindy, thank you for answering that. I think we spoke a little bit, in our tribal system, we're lucky that a lot of our EMRs are kind of starting to become more fluid with using the same profile. And the fact that we're able to kind of tailor our major medical record to be able to capture it in the same place across the system has been super crazy helpful. But that's something I think also the work of the palliative care team can do and does well is, we facilitate that a lot of the times. We will send our customers home with multiple copies or fax them to their rural sites or whatever. We encourage them to share that information, and typically at the end of the conversation, we're super happy to say that most of them are pretty jazzed about it. And so a lot of times they go home, with copies for their healthcare agents, copies for their rural health system, and scanned into the medical record, and an extra just to be fun. So just however we can do it, typically we just typically see, when advanced care planning is done and done well, and people feel really excited that has really truly captured their goals and values, they're really excited to share it. And so thank you for bringing that up, because it is important to be able to kind of encourage that and facilitate that if at all able.
Great. We have just about 2 minutes left if anybody would like to put another answer in the Q&A box. All right. Well, with no other questions being entered, I'd like to thank, oh wait, we have one more. What's your favorite place to visit in Alaska?
That's a good question. I'm from the Kenai Peninsula, so I have to say Kenai Peninsula. Homer is one of my very favorite places. Seward, Seldovia, Kenai, the beach. On a sunny day, there's nothing. It does not compete with anything else. So that's home.
And then I would say, I agree with Ronna, like Kenai is gorgeous. Another place that we love to go, it's called Hatcher's Pass. And so every year we go berry picking. So my daughters will spend hours and hours in Hatcher's Pass, which is up in the mountains and just spectacular views. And it's just amazing. So Alaska is absolutely incredible.
Thank you. And then the last question that we have is, what is the name of that farm again?
Oh,
Farm.
the farm, I'm trying to think.
Were you referring to Hatcher's Pass maybe? Or Homer or Seldovia, Seward? What else are we talking about? I'm not sure.
There are beautiful farms here too, so especially up in the valley.
Oh, where you go to pick the berries with your family.
Oh, got it. Okay. Yeah, it's called Hatcher's Pass in the Chugach Mountains as well, which is really located right here. There's something called Arctic Valley, which is another just beautiful mountain pass. And so those are two places that we love to go to pick berries. And they're really not that far away. Like Arctic Valley is only about 40 minutes from where we live in Anchorage. And Hatcher's Pass is about a little over an hour, hour and a half to get there, but well worth it. So.
I spelled it out because that can be confusing. It's not a farm, it's the wilds, but it's an area.
Oh, that's true. I didn't even think about it. So subsistence is really big here. So just know in Alaska, yeah, you don't have to go to a farm to pick berries. They just grow wild and you just have your favorite berry picking spots, which is so special. So I forget about that.
Thank you. So now I would like to thank both Christopher and Ronna for joining us today to sharing your resources and helping us gain more knowledge on the many facets of advanced care planning. So in the closing, I'd like to remind everyone that today's webinar was recorded and the audio and presentation slides will be made available online at cms.gov. And so thank you again for joining today's webinar, and our session is now concluded.
Thanks, everybody. Bye.